This talk is about anatomical localization of non-epileptic, non-paretic horizontal jerk nystagmus. In this frame, you can see a sagittal brain specimen. To it, I will add the structures constituting the lateral gaze model that I have found most useful in clinical practice. These structures are the vestibular nuclei, the two-way connection between the vestibular nuclei and the flocculus and nodulus of the cerebellum, prepositus hypoglossi nucleus. This nucleus is the most unique structure of the horizontal gaze integrators. The horizontal gaze integrators are in charge of holding the eye's position during lateral gaze to assure foveal vision. The two-way connection between the vestibular nuclei and the prepositus hypoglossi nucleus, the contralateral prepositus hypoglossi nucleus, the prepositus hypoglossi nuclei interconnections, inferior olivary nucleus, prepositus hypoglossi nucleus, connections with inferior olivary nucleus, the inferior olivary nucleus, contralateral cerebellar connections, cranial nerve 8, vestibular apparatus, the paramedian reticular formation, better known as the PPRF, the vestibular nuclei, communication with the contralateral PPRF. Some authors and myself have used the term ascending tract of theaters for these fibers, but I think it is best to drop this term because this term has also been used for a connection between the vestibular nuclei and cranial nerve 3 nucleus, and a structure not included in this model. Next, we have cranial nerve 6 nucleus and its connection with the PPRF. I have now added the median longitudinal fascicle contacting with the opposite cranial nerve 3 nucleus, specifically with the subnucleus of the medial rectus. I will now represent a coronal representation of the model to which I will add some other structures. The vestibular apparatus, cranial nerve 8, vestibular nucleus, prepositus hypoglossi nucleus, interconnections between the prepositus hypoglossi nuclei, prepositus hypoglossi nucleus vestibular connections, prepositus hypoglossi connections with the inferior olivary nucleus, the flocculus and nodulus of the cerebellum are now added. Their two-way connection with the vestibular nucleus, the inferior olivary complex connections with the contralateral flocculus and central nodules is represented in this frame. The crossing fibers from the vestibular nuclei to the paramedian pontine reticular formation, the PPRF connections with the ipsilateral cranial nerve 6 nucleus, the crossing medial longitudinal fascicle fibers, and the medial rectus subnucleus of the nucleus of the third cranial nerve. I have now added a histological specimen of the upper midbrain and represented the eyes with their respective medial and lateral recti. Now you can see represented the innervation of the lateral recti by nuclei of cranial nerve 6 and the innervation of the medial recti by cranial nerve 3 nuclei. Finally, you can see incorporated the fibers from the cerebral cortex area 8 innervating the contralateral PPRF. Now let's talk about nystagmus. Remember that we are addressing non-epileptic, non-paretic horizontal jerk nystagmus. Based on the model we built, we can surmise that the fast correcting phase of horizontal nystagmus, represented by the straight lines in this tracing, which I have now colored green, are the result of the activation and normalcy of all structures from the PPRF to both eyes. These structures are isolated in this frame. I have now reintroduced the total figure and color red the slow components of the nystagmus, and now isolated those structures that generate the slow component are not involved in the generation of the fast component, nor are they shared with the fast phase structure involved in the production of eye movements. These structures are listed in this frame: the vestibular apparatus, cranial nerve 8, vestibular nuclei, the cerebellum, specifically the flocculi and nodulus, inferior olivary complex, prepositus hypoglossi nucleus, and their interconnections. Damage to any of these structures may produce non-epileptic, non-paretic horizontal jerk nystagmus. When the damage involves the vestibular system, that is the vestibular apparatus, cranial nerve 8, or the superior, inferior, or lateral vestibular subnuclei, if the dysfunction is on the right side and it results in decreased vestibular nuclei stimulation, as stated in this heading, the characteristic oculographic finding that occurs consists of left beating fine nystagmus in the primary position that, upon gazing to the left, the side of the direction direction of the fast component increases in frequency and amplitude. Notice that the slow component is linear. I am adding this diagram to explain the nystagmus direction. I will use as an example of decreased vestibular nuclei stimulation what occurs as a consequence of decreased tonic firing of the right vestibular apparatus. Such occurrence translates into a relative excess of discharges at the left vestibular apparatus. Hence, the left vestibular nucleus becomes hyperactive, then the right PPRF, then the right abducens nucleus, and the left medial rectus subnucleus. This leads to a slow deviation of the right eye laterally and the left eye medially. This is followed by correctional activation of the right cerebral cortex area 8, stimulation of PPRF, and ultimately to fast jerks in the opposite direction to the slow drift. So we looked at the result of decreased stimulation of the right vestibular system due to decreased tonic firing of the right vestibular apparatus. Now let's look at what occurs with dysfunction producing increased stimulation of the right vestibular nucleus. In such cases, the oculographic findings reveal a right beating fine nystagmus in the primary position that increases in amplitude and frequency when looking to the right. And as in the prior example of vestibular dysfunction, the slow wave is linear. Once again, I am introducing the horizontal eye movement model to explain the direction of the nystagmus. Notice in this model the increased activity of the right vestibular apparatus leading to a slow drifting of the eyes in the opposite direction to the increased firing of the vestibular apparatus, and the compensatory fast jerk in the opposite direction to the slow eye drift towards the tonic discharging vestibular apparatus. So now let's change the tune and consider a situation involving damage to the right neural integrators, the prepositus hypoglossi nucleus, and the medial vestibular nucleus and its collaborators, the cerebellum and the inferior olivary complex. Damage to these structures always produces inhibition, leading to an oculographic pattern characterized by, in the case of right-sided involvement, 2. Right beating coarse nystagmus, present only when gazing to the right. As you can see here, notice that the slow phase is not linear. Not illustrated in this oculogram, but an important point is that the nystagmus increases in amplitude and frequency with extreme right gaze. In this frame, I have reintroduced the model for horizontal eye movements. In this illustration, the eyes are willfully looking to the right, the eye position triggering the nystagmus. The right-sided integrator dysfunction is illustrated by an empty red arrow. Such dysfunction, while looking to the right, will cause failure of gaze holding, so the eye drifts towards the mid position, as represented here by the displacement of the cornea. As you can see, this is followed by a jerk in the opposite direction. Before closing the curtain, I will make two more comments. The first one is depicted in this table. The two types of nystagmus: the fine nystagmus in primary position beating towards the side opposite to the hypofunctional vestibular system lesion, or the coarse beating gaze nystagmus towards the side of the neural integrator system lesion, may occur in patients with a vestibular nuclear lesion and in those patients with damage to the tracts communicating some of the structures here listed. The second comment is regarding Burns nystagmus. Burns nystagmus refers to simultaneous appearance of a fine nystagmus present in primary position that worsen when looking in one direction and a gaze-evoked coarse nystagmus in the opposite direction. In this frame, you can see the characteristic oculogram of Burns nystagmus due to left-sided pathology. Notice the fine nystagmus in primary position jerking to the right that increases in amplitude and frequency when looking in the direction of the fast component, but maintains all the other characteristics present in primary position, and a coarse left gaze, left beating nystagmus. This type of nystagmus classically occurs with left cerebropontine angle tumor compressing cranial nerve 8, the brainstem, and the cerebellum, as you can see in this MRI. Please take a few seconds to observe the clinical characteristics of Burns nystagmus. Burns nystagmus is due, as you can surmise from the previous comments, to a lesion that simultaneously affects cranial nerve 8, that is, a component of the vestibular system, and the functioning of the ipsilateral case-holding neural integrator system. Thank you very much for your attention.